Welcome to this week's Mountain West ADC Echo. My name is Brian Wood, Medical Director, and I will turn it over to today's speaker.
Very nice to be here as always, and I paired with some other people to give a CROI update at our AIDS Clinical Conference a week ago. My assignments were to talk about cure abstracts and a few antiretroviral abstracts as well. So that's what we'll talk about this morning. One talk that got a lot of buzz at the conference was the prospect of a second true HIV cure. This was a patient who was treated in London and is known as the London patient. And I'll walk through his case history and some similarities between him and Timothy Brown, who is the only other patient cured of HIV. So the case history for this N of 1 is that he was diagnosed with HIV in 2003. He was not on therapy for his HIV. He elected not to treat it. Was diagnosed 10 years later with Hodgkin's lymphoma and was started on a triplet at that time, and his viral load suppressed. And then in anticipation of going on to therapy for his lymphoma, his triplet was changed over to a raltegravir anchored regimen. He failed multiple rounds of chemotherapy, and he was then set up for an autologous bone marrow transplant. But as happens in these cases, they could not mobilize enough cells for him to get an auto hematopoietic stem cell transplant. So then they started the search for an unrelated allogeneic stem cell transplant and did identify somebody who was a close match, 9 out of 10 HLA alleles, and that person was also homozygous for the CCR5 delta 32 mutation, so that person does not express CCR5 on any of their cells. His ART around the time of that transplant was changed to rilpivirine. So his conditioning regimen, I don't know much about this, but this is a relatively low dose conditioning regimen of lomustine, cyclophosphamide, cytarabine, and etoposide or LACE conditioning. His day 0 was May 13th in 2016. That's when he got his infusions. And his post-infusion or post-transplant course was complicated. He had gram-negative sepsis, a dental abscess. He might have had some mild colitis that was related to GVHD. He also had reactivation of both CMV and EBV and was treated for those infections with ganciclovir and rituximab. By a month out, so day plus 29, he was fully engrafted, so all of his cells were CCR5 minus. He had no host cells left. At day plus 510, so that was September of 2017, he stopped antiretroviral therapy. And at the time that this case was presented at CROI in February of this year, he'd been off of therapy for whatever the difference is between 510 and 1028, 518. And his viral load remained undetectable. So this is just a graphic representation of his course. Before transplant, remember, he was not on therapy until he got a triplet and then raltegravir, so he had detectable virus up to 1,000 copies or so. Once he went through the transplant, his viral load was suppressed on a rilpivirine anchored regimen and stayed suppressed. This is day 510, which is after his transplant when his ART was stopped, and then 18 months later is the time that he was reported at the CROI conference. So the results, single genome sequencing of all pre-transplant HIV isolates, and they had some, demonstrated that all of his isolates were CCR5 using. He had no X4 using virus when they looked extremely carefully down to single genomes. So all R5 using virus. At 33 months, his plasma viral load was less than 1.4 copies, which was the limit of detection. They also wanted to make sure that he wasn't surreptitiously taking antiretroviral therapy that was responsible for his viral load being undetectable off, and so they looked for ART in blood, and that was all negative. To look for residual HIV, they first looked at HIV DNA and CD4 positive T cells using a droplet digital PCR and found no signal, a rare signal by that very sensitive type of PCR, and no signal by a quantitative PCR. And by 16 months after transplant, he started to lose bands on Western blot and also was losing his CD8 response to HIV, so demonstrating that his immune system wasn't reacting to any residual HIV. He was losing his immune response. And then finally, they did QVOA, or viral outgrowth assays, at 3 time points after his transplant, large numbers of cells, again trying to cultivate HIV ex vivo from those cells, and all those studies were negative. So this is just a plot of his HIV DNA in green, and you can see as soon as he switches over from a host immune system over to donor immune system, so he's 100% chimera, 100% donor cells, then his HIV DNA level goes to Zippo, and then you can see that the time points where he had viral outgrowth assays performed, those 3 blue arrows at the very bottom, and all of those studies were negative. So what are some differences and some similarities between the London patient? And by the way, this guy does not want his identity shared, so he'll always be known as the London patient. The London patient was, before he got transplanted, he was wild type for CCR5, so his immune system expressed CCR5. Timothy Brown was a heterozygote, so he had one defective allele, but all of his cells expressed CCR5 because he had one intact allele. They both were infected with R5-using virus. The London patient had lymphoma instead of leukemia. He had a single transplant instead of 2 transplants, which Timothy Brown obtained. And he was not irradiated. The London patient had no TBI and also had reduced intensity conditioning. So that's a key difference, I think. They both received some treatment for GVHD with some depleting antibodies. They both had only mild GVHD, and they both were 100% donor after their transplant. So what does this case tell us? I think one key finding from this case is that this patient is probably cured, and he did not require intense chemotherapy, and he did not require total body radiation. So we wondered, why was Timothy Brown cured? Was he cured because we just blasted him and eliminated all of his donor cells? Or did he have graft versus donor cells and eliminated HIV-infected donor cells? Or was it just that they both expressed no CCR5 in follow-up? And I think that that's probably the key thing that we learned from this second case, is that you don't have to be blasted with chemotherapy or radiation. You don't need bad GVHD to get rid of any residual HIV. You just have to be 100% CCR5 minus. It doesn't really matter how you got there. So I think this holds some promise for some strategies that are looked at to cure HIV without going through transplant, using gene editing to get rid of CCR5 from people. That might be a viable strategy in the future. So I think we did learn something from this second case. There was one other cure patient, the Dusseldorf patient. It didn't get a talk, it was just a poster, and I think it's because it's a little early to tell whether or not this patient is cured. Similar story, 49, he got an allogeneic stem cell transplant, again from a CCR5 minus donor for AML. He had a rocky course, his AML relapsed, and he got multiple courses of 5-ARC and donor lymphocyte infusion, and eventually he achieved remission. In October of 2017, his immunosuppression was stopped, and in November, so just last year, so only 4 months before the CROI conference, his ART was stopped. And just like the London patient, he had a rare positive DNA signal by droplet digital PCR, and also had a rare signal in lymph node by RNA and DNA scope. So those are just telling you that they could detect some nucleic acid that is part of HIV, but doesn't tell you anything about whether there's any replication competent intact proviruses that remain. His viral outgrowth assays are similarly negative, and his antibody levels are declining. So he's only 4 months out, so I think the jury's still out. We don't know if he's going to be cured, but I would say if he really is 100% CCR5 minus, then his chances are quite good. Okay, so those were the 2 cure abstracts that I focused on, and then there are a few antiretroviral studies that I think are worth mentioning. And the first I'll group together. These are the Atlas and Flare studies, and they were both looking at using long-acting injectables to treat HIV. So just walking through the setup for each of these 2 studies. They were both phase 3 open-label multi-center studies. The Atlas study had over 600 patients, and they had all been on antiretroviral therapy previously for at least 6 months, and most had been on much longer than that. And these people who were already suppressed, already on a variety of standard antiretroviral regimens, were randomized to either continue that regimen, whatever it was, or to switch over to cabotegravir and rilpivirine orally for a month, and then start getting IM injections monthly. And the primary endpoint was how many people were undetectable at 48 weeks. The FLAIR study was a little bit different, same setup, but these patients were not yet on antiretroviral treatment. So they were newly diagnosed or just hadn't been on therapy. And they were started on dolutegravir plus abacavir 3-TC, so Triumec. And then those had to be less than 50 at 16 weeks. And then at that point, they were randomized either to continue the dolutegravir anchored regimen or to switch over to cabotegravir and rilpivirine, again taken orally for a month, and then and then after that monthly IM injections. Same clinical virologic endpoint. So their baseline characteristics were fairly similar. I won't march all the way through them, but you'll notice the median for the Atlas study, median time on antiretroviral therapy was 4 years. For the FLAIR study, nobody before treatment was suppressed, and the plasma viral load over 100,000 was the case in 20% of those people. They all suppressed after, they all must have suppressed after starting the dolutegravir regimen. And here's the outcome. So virological success, the green bar is the IM injectables, the purple bar is the continuing on oral therapy, and there was no significant difference between those groups in either study. There were some, is this going to work? Yeah. There were some breakthroughs and failures. So on top is the Atlas study, and over here, this is a busy slide, I apologize for that. There were some baseline resistance mutations here that you can see for these 3 patients, some of them in RT, some of them in the integrase gene. And there was one patient, this guy here, who picked up some integrase mutation and also the signature mutation for rilpivirine, and he was somebody who failed therapy. So there was one failure with development of resistance. And then down here in the FLAIR study, here their baseline resistance-associated mutations were only in integrase, and there were 3 people who picked up integrase or non-nucleoside RTI mutations in follow-up as well. So there were some failures with resistance in the injectable group. This is data looking at the levels of drug in plasma on people who got injectables. So Atlas is the top 2 bars, and the green is cabotegravir, the purple, or blue rather, is rilpivirine. And the IC90, so the level above that you need to suppress 90% of HIV, the drug levels were higher than the IC90 for both cabotegravir and rilpivirine in both studies at all time points. So I think a key finding from these studies, because we already kind of know this from the Latte study, and we have data from the Latte study that go out even farther, at least 96 weeks, showing that cabotegravir and rilpivirine given every 4 weeks or even every 8 weeks works great. But I think the key finding of these 2 studies was satisfaction. And 97 and 99% of those who were getting the injectable drugs preferred that to taking a pill every day. Kind of a surprise to me. So conclusions for both of them, monthly injections was non-inferior to oral therapy. And as I mentioned, there were some virological failures, but they occurred at a low rate, and there was some development of resistance as well. But as another step down the road, I think, toward using injectable medications. So that's it for those. And then the last study I thought I'd review, I've got 1 minute, is the Dawning study. This, I think, is relevant to the second case that we're going to talk about today, and an issue that comes up in echo sessions quite a bit. So I think it's worth paying attention. So this was a non-inferiority study comparing dolutegravir plus 2 nukes to Kaletra plus 2 nukes in patients who were failing a non-nucleoside regimen. So those were the criteria for enrollment. You were randomized 1-to-1 and stratified by your RNA level and the number of fully active NRTIs you had in your regimen. Primary endpoint was undetectable at 48 weeks. So there were 600 patients or so. 80% of them had received less than 2 fully active NRTIs, so kind of suboptimal therapy. NRTI resistance was present in 90% of these patients at baseline. The 184V mutation alone or with some others was present in 82% of these patients. K65R in 30% and greater than 1 TAM in 24%. So of the 624 who were randomized, of those with a 184V alone or other RAMs, 84% of those people were put on FTC or 3TC. 15 who had the K65R were put on tenofovir, and 86 with greater than 1 TAM were put on AZT. You'd think, oh, this is a prescription for disaster. But the results are those that had the 184V mutation and were put on 3TC, if they were on dolutegravir, 85% of those people stayed undetectable. 72% if they were put on lopinavir as the anchor stayed undetectable. So dolutegravir beat lopinavir in the setting of NRTI resistance in the backbone. Shown another way, the blue bar here is those who were given dolutegravir plus 2 nukes, and they did quite well compared to the group given lopinavir in the orange. And then the key here, if you had the 184V and you were treated with XTC, that's not ecstasy, XTC meaning FTC or 3TC, if you got dolutegravir as the anchor, still 85% of those people were undetectable. And if you got lopinavir, 72%, so not very different from the overall group. What about patients who were put on TDF and had the K65R? Almost 90% of the people, regardless of their anchor, also stayed undetectable. And if you were put on AZT but had a bunch of TAMs, again, if your pairing drug was dolutegravir, you did better than if the pairing drug was Kaletra. So just giving support to the idea that maybe nuke-light therapy, depending upon what your anchor is not such a bad idea. There were some resistance mutations that developed. This slide is kind of busy. These were the emergent resistance that happened in the patients who got dolutegravir and the emergent resistance that happened on the patients who got lopinavir over in that last column. So conclusions from the Dawning study: dolutegravir plus 2 nukes is superior to lopinavir plus 2 nukes in people who are failing a non-nuke anchored regimen. And there's a good response to dolutegravir plus 2 nukes regardless of pre-existing resistance to one of the nukes, including when people were put on FTC, 3TC, even though they had the 184V mutation.
Thank you for watching this edition of the Mountain West HIV Project Echo Didactic Series. If you're interested in other talks, we invite you to subscribe to this YouTube channel. You can select the red subscribe button. You can also find additional talks by searching YouTube for MWATC Project Echo. Until next week's edition, this is Brian Wood, Medical Director, signing off.